everyone, and welcome to the 2025 Leading Developments and Current Questions in Lung Cancer, hosted by Global Resource for Advancing Cancer Education, or GRACE. I'm Dr. Jennifer Marks. I am your chair today, and our aim for today's uh, discussion will be aimed at the latest data, especially highlights from ASCO 2025, clear and useful information for patients and their caregivers. We'll move through some concise updates in small cell lung cancer, as well as immunotherapy, cellular therapies, and novel targets, and touch on EGFR updates as well. We'll then follow and conclude our meeting after a panel discussion to connect some of these dots and answer pending questions and common questions posed by patients. Quick housekeeping before the session is started, in that this is a public educational tool and its use will be for education purposes. Please keep your microphones and cameras off when you're not presenting. And for the panel at the end, we'll have everyone turn their cameras on. And with that, let's begin. So our first speaker is Dr. Alyssa Cooper. She is a thoracic medical oncologist and my colleague at Dana-Farber Cancer Institute, as well as an instructor in medicine at Harvard Medical School. She focuses on small cell lung cancer and antibody-based strategies, and will cover some of the updates on small cell lung cancer from ASCO 2025, specifically utilizing Tarlatamab and its maintenance approaches. Alyssa?
So very pleased to be here. Small cell lung cancer is a topic that's near and dear to my heart. As my good friend Misty Shields says, it's small cell lung cancer, but there's nothing small about it. There is so much going on in this exciting field right now. There is a ton of new research, and I've just picked out a few things for us to review tonight. And there's many more exciting trials going on that we can review at another presentation. Tonight, we're going to talk about extensive stage small cell lung cancer. So small cell lung cancer that has spread or is metastatic. First, we'll review Tarlatamab, which is a T-cell engager, a new kind of immunotherapy that became standard of care in the second line after chemo and immunotherapy in the first line. This is an FDA-approved regimen, which was approved last year. We'll also talk about the new maintenance regimen of immunotherapy and lurbinectedin, which is a second-line chemotherapy. This was just approved this month in October 2025, so hot off the press. And we'll also review Tarlatamab, as I discussed before, as added to this maintenance strategy. This is not a currently approved regimen, but we'll review the data. Just to kind of orient you, we're not going to go through this whole flow sheet. But for patients with small cell lung cancer, if we start up here, then we move over to this extensive stage small cell lung cancer. So patients with small cell lung cancer that has spread. What we're talking about in this first part of the talk is that patients who have good, what we call fitness or performance status, who are able to tolerate pretty tough treatments for cancer, usually get chemotherapy and immunotherapy for 4 cycles, and then they get what's called maintenance immunotherapy or ongoing immunotherapy until either the patient has an issue or the cancer grows beyond that. So we're going to talk about that paradigm and changes there. We also are going to talk about patients who have had cancer that has grown after that. As we talked about, sometimes patients do have cancer grow even on this maintenance immunotherapy. And what we'll talk about here is changes to the second line regimen, which typically would have been standard sort of second line chemotherapy prior to all of these new developments. So to orient you, tarlatamab is a very new agent, but very exciting. It's a new kind of immunotherapy that targets a marker on the small cell lung cancer cell, as well as a marker on the T cell, which is an immune cell, and sort of brings the immune system to the small cell lung cancer cell and allows the immune system to kill the cell and then sort of burst it open and kind of is very effective cancer killing in a way that we didn't have before. The study that I want to review is presented by Dr. Rudin at ASCO this year, which is the big meeting. Basically took patients who had small cell lung cancer, had disease that had grown after getting chemotherapy and immunotherapy, and they were randomized 1-to-1 to get tarlatamab or physician's chemotherapy of choice. Now, this was a global study, so that meant that the physician was free to choose what chemotherapy within the realm of standard of care, and that varied based on the part of the world that patients were enrolled in, but here's the breakdown over here in case you're interested. This is a busy slide, but I just want to emphasize that patients in each of these two categories, about 250 in each arm receiving tarlatamab and chemotherapy, were quite evenly split in their characteristics, which we always look for. And this was what we call like a really blockbuster study, really very exciting results where patients who received tarlatamab had a markedly improved what we call overall survival. So they lived longer than patients who received chemotherapy. And this was a statistically significant and what we call clinically meaningful difference. Like it really mattered to patients and made an important difference in their care. Often what we do is try to figure out, does this benefit extend to all different patients who received tarlatamab? You know, are there differences depending on age or sex or race or treatment history or sites of disease? And basically what they demonstrated is that the benefit for tarlatamab was there despite all of those different kind of variables that you can look at. Tarlatamab was also associated with better responses, meaning that the disease shrunk at an increased rate compared with chemotherapy, and also had a longer what we call duration of response. So once the disease had shrunk, it stayed shrunk for a longer period of time than compared with chemotherapy as well. And probably most important for patients, and that you rarely see this in an ASCO presentation. So I thought that this was very impressive, that they did some patient-reported outcome work here and show that patients actually even had improved symptoms. So better dyspnea, which means shortness of breath, better cough after 18 weeks with tarlatamab compared with chemotherapy. We talk about safety hand in hand with efficacy with these therapies, because it's really important for us to make sure that our therapies are not harmful to patients, even if they can kind of help some people. Tarlatamab has a very distinct side effect profile that has to do with overactivity of the immune system. And even in that setting where the immune system can get really revved up and can cause fevers and even to, cause people to have low blood pressure or low oxygen and even need to be in the hospital, even then, the authors here were emphasizing that in general, tarlatamab was considered to be more safe than chemotherapy. This is what I'm talking about here, this immune system overactivation. These abbreviations here are called cytokine release syndrome and immune cell effector associated neurotoxicity syndrome. Those are mouthfuls, but basically what it means is that the immune system is getting too revved up, and patients can get quite sick from that. Basically, what this slide is saying is that patients had general sort of mild manifestations of these immune reactions, and they were not significant or serious overall. So the key takeaways is that this was an extremely effective therapy. It was generally a safe and tolerable, and this is sort of now the new standard of care for patients after they've received first-line chemoimmunotherapy. If the cancer grows beyond, this basically was the gold standard. Tarlatamab is the next step. Now I'd like to review this maintenance therapy change. So as I discussed before, the standard of care is for patients to receive maintenance immunotherapy. That might be a drug called atezolizumab, or it might be a drug called durvalumab, depending on the regimen that your physician chooses. And they are not really different from each other. They're the same kind of drug. So there's not really a difference here. But in this trial, the investigators took atezolizumab, which is one kind of immune therapy, and added lurbinectedin, which is a chemotherapy, after patients had this sort of induction phase. So everybody got the induction phase, which is the standard of care, chemo and immunotherapy together. Then, if their cancer did not grow, which happens to most people, but unfortunately doesn't happen to everybody. But if their cancer did not grow at this point, they were randomized to chemo and immunotherapy, lurbinectedin and atezolizumab versus atezolizumab alone, and were followed for outcomes. Here we can basically see, again, just about 250 patients in big trials here. These are big randomized phase 3 trials. And they're trying to emphasize here with these arrows that very important clinical characteristics that we look at were quite similar or nearly identical in each arm here. And what they showed here is what we call progression-free survival, meaning time until the cancer grows on this therapy. And what they found was that there was significantly longer progression-free survival with the combination arm compared with the monotherapy arm or the single therapy arm. So this, as you can see, these curves are separate. The blue line did much better. Again, as I showed you with the other therapy here, every single subgroup of patient here did generally tend to favor the combination arm versus the single immunotherapy arm, although not all of them perfectly, but generally that's sort of the trend. And this trial also did demonstrate what we call overall survival, meaning patients did not only live longer without their cancer growing, but also lived longer overall. So this did have a statistically significant overall survival benefit. And that held up again in generally in most patient subgroups. Now, the big issue here, and very important for patients and for physicians when they're sort of discussing the pros and cons of any regimen, is the safety and the toxicity of any regimen that we choose. And I think the thing that stuck out with this presentation is that the combination therapy did seem to have significantly more side effects. And so when we talk about these are AEs, as adverse events, so those are side effects basically that happen on a trial. And when we say grade 3 or 4, those, according to doctors who treat patients, are quite significant or serious. That generally could mean patients might be in the hospital. They're really significantly impacted by those. And you can see here in the combination arm that the treatment-related grade 3 or 4 adverse events were quite a bit higher in the combination arm compared with the immunotherapy alone arm, which can be, really important to take into account. So that's something that we really need to continue, consider when we're making decisions for our patients. Okay, so the key takeaway was that this is a new regimen, definitely can be considered and is worth a conversation, but I think importantly, in my view, does merit some discussion of the risks and benefits given the more intense side effect profile. Okay, lastly, we'll talk about tarlatamab, which is that new kind of immunotherapy added with our kind of standard immunotherapy in the maintenance setting. And this was just presented at World Lung only last month in September of this year. So just to remind you, it's the new kind of immunotherapy that's bringing the immune system to the small cell lung cancer cell in combination with kind of our old standby immune checkpoint inhibitors. So tarlatamab, everyone back had induction chemoimmunotherapy. Then they were not randomized, but they studied two groups of patients who received tarlatamab plus atezolizumab or tarlatamab plus durvalumab, which, as you recall, are sort of those standard checkpoint inhibitors that we use in small cell lung cancer. And again, this is sort of like the characteristics of the patients. They're very evenly split. And basically what this study was trying to show was whether this combination is safe, whether tarlatamab, the new immunotherapy, is as safe in combination with the old kind of standby immunotherapies. And what they're showing here is that actually overall, that this bar graph is kind of a lot to look at, but basically, some of these immune related adverse events happen kind of upfront, but tended to decrease over time. And generally, we're low grade and manageable. But I think what was really exciting about this trial, which is as an early phase trial, is not really intended to really test the efficacy as much, but overall survival with tarlatamab, with an addition to the addition of atezolizumab or durvalumab, showed a significant improvement in overall survival than we're used to seeing for this patient population compared with historical controls. Overall survival of more than 25 months, which is really quite unprecedented in small cell lung cancer and very provocative and exciting. And so in general, this basically showed that this combination was safe, and that it did have noteworthy clinical outcomes. Now, there are going to need to be more studies because this was an early phase trial. This did not have as many patients as the other trials. It only had, I'll back up for just a moment, it only had about 40 or 45 patients in each arm. So there were under 90 patients in the entire study, which is different than sort of these large 500 patient trials. But it is really provocative, I would say, and exciting, and potentially might herald a change in the standard of care. So with that, I'll end my slides and look forward to the discussion later on.